So, these are the DSM-4 diagnoses of depression, basically. And again, these are the criterion-based diagnoses, but there is the idea, even an adjustment disorder is a less severe, but still considered abnormal and pathological problem, but less severe than the episodic but severe depressive symptoms that happen in a major depression. And then dysthymia is a more prolonged, at least 2-year course of more attenuated depressive symptoms. And then there's minor depression as well, which used to be in the DSM-4, isn't now, but I think maybe something like that in the future with the DSM-5. But it's an episodic cluster of mood symptoms that are less severe. There aren't as many. You don't have to have as many, basically, to meet that diagnosis. But it's something that's really just a research criteria now. It's not actually in the DSM. And then, of course, bipolar disorder is something that, we want is important, that mainly with respect to treatment, that we screen for. And it's a hard thing to screen for, but, you can have people with bipolar disorder have mostly major depressive episodes, but occasionally have manic or hypomanic episodes. But there's nothing necessarily about cancer or palliative care population that's going to predispose someone in any way to having bipolar disease if they hadn't already had that predisposition.
Yeah. Just before you leave this slide, adjustment disorder is a diagnosis also that gets reimbursed from insurance companies. Yeah. If you don't have a diagnosis from DSM-4, you don't get reimbursed from insurance companies. Yeah. So one of the questions is, what is a true adjustment disorder? Because I think it's thrown around because of many reasons, not all of them are reasons.
Yeah, and I don't know how many times I've ever told a patient that they have an adjustment disorder. But I think you're exactly right that, everyone I'm seeing needs kind of a psychiatric diagnosis, more or less. But it's very hard. I mean, an adjustment disorder has to be, you have to have a stressor, and then I think it has to be for a month or more where you have depressive symptoms, or anxiety symptoms, or mixture, or even behavioral disturbance or conduct disturbance that's not mood related. But adjustment disorder with depressive features has depressive symptoms related to a stressor that's beyond what's normally expected. And that part is the hard thing, because it's the hard thing. You can look at it as the difficult thing, but it also leaves some leeway for us as clinicians to sort of, on an individual basis, based on our experience, sort of decide what's normal and what's not. It's hard to say, but I think it's important to just kind of get a sense of what's distressing to the patient. But as I alluded to before, there's a certain level of sadness and fear and grief that's experienced normally at various phases of one's course with illness. I think if it's a little prolonged, if they're not if a patient isn't, for instance, I guess after they're diagnosed with a cancer, or after they've completed treatment and they're in remission, if they're having pervasive rumination or fears of recurrence, you might say that that's an adjustment disorder with anxiety features. Whereas other people might, when they're in remission, be more flexible and able to sort of move forward with their life. You might not see that with someone with an adjustment disorder. So these are some of the difficult. So we talked about anhedonia, how that's kind of difficult to address in the palliative care setting. We just talked about sort of the difficulty of determining what's normal in terms of diagnosing an adjustment disorder. And then the other thing is, with depression, there's 3 criteria. 3 of the 9 criteria are what we call neurovegetative symptoms, which are the somatic symptoms, as opposed to the more cognitive or sort of emotional symptoms that are part of the depression. And it's harder, again, to assess these, in theory, in the medically ill, because they're experiencing somatic symptoms from their illness. So how do we deal with this? Some might say exclude the somatic symptoms, but that then becomes really hard, because then you only have you have the depression and the anhedonia and 2 other symptoms, and unless you and if you were to exclude it, you would only meet criteria for depression if you had those symptoms, and so that becomes complicated. And the other option is to include them, even if they might be related to cancer or a physical illness. And that's actually been found to be obviously you're going to end up with a higher rate of depression, but it's found to be, when compared to, separately research diagnostic criteria, to be a valid approach. There's also something called the Endicott criteria, which is on the next slide, which sort of substitutes other symptoms for the neurovegetative symptoms. And then something that has been validated has been basically a short 1-question screen: are you depressed? And that seems, or some people would say that there's also been validation with using a 2-question screen, which are the 2 core symptoms, asking about depression and asking depressed mood and asking about anhedonia. So this is how we these are the criteria that we substitute the neurovegetative symptoms with: depressed appearance, social withdrawal or decreased talkativeness, brooding, self-pity or pessimism, and a lack of reactivity. You can't be cheered up. Instead of using some of those physical symptoms there that might be affected by physical illness or treatment. These are some of the, I think I talked about this before. Some of these diseases are highly associated with depression in palliative care. So some of the risk factors for depression are the same in palliative care setting, are the same as those in the general population. A prior history of depression certainly remains true in cancer patients. Specifically, if one has a tendency towards narcissism or pessimism or low self-esteem. In the general population, as I mentioned, depression is twice as prevalent in women as it is in men, but this is not true in all studies of cancer patients, advanced cancer patients. In fact, some have found the opposite to be true, but I'm not sure what hypotheses have been generated in that regard. In terms of age, it's generally, in the general population, an illness of the young. It's more prevalent in patients under 45. This is true, again, in cancer patients, though it's hard to say, because cancer, even though it happens in the young patients, is generally an illness of older patients. Let's see. Certainly psychosocial support is important, but after a while, you really have to sort of make sure that there are strong social supports present, because, as we know, caregiver strain is a big issue in palliative care, and even if someone has, in theory, social support from surrounding family, sometimes that's not enough, or it can eventually lead to strain on the caregiver, and it no longer acts as a buffer in preventing depression. And pain is also, has been found, depression's been found to be 2 to 4 times as prevalent in patients with pain, and it's more pronounced if cancer pain is related to metastases. there is a lot of evidence that depression itself directly may amplify the pain experience.